answer those for you. I do not have anything, nor do any of the Hub team members have a financial arrangement related to the content that we're going to be discussing today. So the goal is to go over kind of best practice models and public domain tools for assessment and screening of the substance use disorder population. So just providing a little bit of information about the importance of screening, some models that really are good underpinnings of that. So you want to be screening both substance use and their co-occurring conditions. And then the two models that I'm going to discuss, ASAM and Aspert, how those routinely include universal screenings. And then at the end, I'm going to show you the common screening tools that can be used in any primary care, behavioral health specialty setting, whatever setting. They're public domain, so you can freely access them. You don't have to pay for them. And then I'll just give you a really brief list of other more comprehensive assessment tools that you could use if you so chose. So resources for you that some are free, some you do have to pay for, but I just wanted you to have that resource list. So that's our goal for today. I know we do a lot of this kind of statistics in this group, so I won't belabor the points here, but really just to kind of tie in why it's important to discuss screening and assessment is to recognize that really there's a large portion of the U.S. population, about 136.9 million, the last time this was surveyed, that report drinking alcohol. 16.5 million report heavy drinking, and 24.6 million report current illicit drug use, marijuana being the most commonly used illicit drug. So recognizing that's a fair percentage of people, right, that could hit any kind of healthcare setting. Within specialty addictions treatment, they estimate that about 8 to 9% are going to actually need treatment for a substance use disorder. So not something that they can manage independently, but they're going to need some level of treatment. 2.5 million are actually receiving that treatment. So there's a huge disparity between the people that need it and the people that are actually accessing it. Only about 1% of US adults are going to seek specialty addictions treatment each year. So that means like the people that are coming to a specialty addictions program. So that's due to, the overwhelming stigma related to substance use disorder, the cost, the lack of interest in providers wanting to learn about or work with this population, which of course decreases its availability. So that means that people embedded in a primary care setting, family practice providers, a lot of those folks are really the ones that are going to catch the patients with these substance use conditions. So about 82% of adults, 92% of children will see some form of a healthcare professional. So that means there's a lot of opportunity within the primary care family practice settings, about 1 billion office visits per year, 130 million emergency department visits per year, where we could be capturing this population and maybe funneling them into, or even treating them in those settings, because again, a smaller percentage are going to need specialty substance use disorder treatment. So that's kind of setting the stage for the reason why we talk so much about universal screening and having a model of care that uses universal screening, right, to be able to catch these patients. Now, it's important to understand our history and recognizing that screening and assessment is something that really helps us to understand what our patients' needs are and to match them to the right services. Maybe those are services we're providing, or maybe we need to have some ancillary services or transfer to additional levels of care, depending on what the patient needs. But screening and assessment is the first step to helping us make that determination. Screening and assessments also can be tools that we use to track symptoms over time and for an episode of care that we're providing to be able to adjust that treatment accordingly. So it helps us to sort of say, this is their baseline, and this is what we're seeing on an ongoing basis. And then this is the score that we know is going to help us to say, okay, they can move into maintenance care, or their symptoms are in remission, and make decisions about termination or transfer. We have to understand that historically, We have had a complications-driven or diagnosis problem-driven treatment approach. So what does that mean for patients with substance use disorder? Well, it means that they tend to not enter treatment unless they have a problem or a complication. So that means that we're catching patients at their more acute states or when they're really desperate, rather than in a place where their treatment could be handled without specialty care, right? So kind of waiting until the problem or the complication presents, then we treat it, then we discharge them, and then a relapse has to occur before they re-enter treatment. And so you can see that there's a lot of inherent difficulties with that versus taking a client-directed, outcome-informed approach, which you can see is a lot more cyclical. So it really says, okay, we're going to assess all of the biopsychosocial dimensions of the person, not just their diagnosis or their substance use alone. We're going to address the problems and make a list of priorities that are in the service of recovery across all of those biopsychosocial dimensions. So an integrated treatment plan versus a singular approach to just, treating their one substance use condition. And then we monitor progress across those different dimensions on an ongoing basis and step them up or step them down in a continuum of care. But recognizing that this is that substance use disorder is a chronic condition. And so having them engage in this sort of, we discharge them from care, wait until they relapse before they re-enter care, but keeping them in some level of care, ideally at the primary care level or family practice level for a long, long period of time, if not lifetime. So that means that we have to have this mindset of organizing the treatment that we're providing in a couple different chunks. The first is thinking about episodes of care. So an episode of care is defined as the set of services provided to treat particular clinical condition over a period of time. So most recommended episodes are somewhere between 4 to 6 weeks, sometimes 24 weeks for chronic conditions, followed by reassessment and a reevaluation of treatment planning, which is why the minimum recommendation for treatment planning is 90 days, right? So every 90 days, we should be kind of reassessing our episode of care with somebody and making a determination. Do they need something more? Could they tolerate something less? Where are we at? And sort of allowing those bookends of time frame to inform the care that we're providing. The other thing is building a continuum of care and having kind of what we talked about, all of those external partners that are part of the treatment team. When we're thinking about a continuum of care for patients, understanding that they can go all the way up to sort of medically managed inpatient levels of care to all the way down to peer support, kind of 12-step level programming or participating in their community, a church setting. But there's a lot in between that continuum. And so recognizing that patients are going to need different things at different points in time, and they're going to move up and down depending on what's going on. So we need to include those in sort of our screening and our assessment process, and having an idea of, if we're going to adopt a universal screening approach, that the patient population we're going to work with is going to fall into different percentages. So the vast majority of people, if you're not a specialty treatment center like ASAP, where many of us work, if you're in a primary care setting, an emergency room setting, maybe another medical specialty setting, but treating substance use disorder is not the primary thing, then the vast majority of people are going to fall into a low risk category. But you continue to screen because, again, that could change at any point in time. Then you have a smaller percentage, somewhere between 8 to 9%, that are going to fall into a risky use category. And we're going to be able to apply a lot of prevention and sort of brief intervention to help them shift down from that risky to low risk, or education. There's lots of things that could be provided there. An even smaller percentage are going to fall into harmful, and a smaller percentage into an actual dependent, or what would meet criteria for a use disorder. So you can see, if you're screening everybody, you're really only going to provide that specialty level of service to a small percentage, but the vast majority you're keeping an eye on with your screening process or your assessment process. So I'm going to introduce two different models that you can use to kind of organize this. One is called Aspert and the other one is ASAM. So ASAM is the American Society of Addiction Medicine Criteria assessment program. And so this is something that you can get training in the community for. It's compliant with DSM-5. It's very data-driven, science-driven. It has specialty areas of focus for tobacco use disorder, behavioral issues like gambling disorder, and specific populations if you're working in a criminal justice setting with geriatric patients, or people that are pregnant or new to parenting, kind of the complexities that come along with those different populations, what to consider. Now, New Mexico is an ASAM state, so that means if you work at a specialty addictions location like where we work, we need to understand ASAM and apply it. But any level of provider can access this training. And it's a nice model to think about if I'm screening everybody, so everybody gets screening, then what do I do with that 8 to 5% that are going to pop positive? And I want to figure out, okay, do they really have a substance use disorder? And if so, what's the recommended intervention plan, treatment plan for them? So ASAM has this really nice process where it goes from screening to diagnosis to leveling. So it tells you the level of severity that you need to work on, their readiness for treatment and relapse potential, and looks at multiple of what's called patient criteria or placement criteria, which helps us to make a determination what level of care, what setting of care is going to be the best fit for this person. And then you use a decision rule to apply that level of care. So you can see it goes from outpatient to medically managed intensive inpatient. So this is a really helpful model to helping determine how patients are going to move across that continuum of care. And if you're doing that initial H&P, or as you do your annual reassessment, to applying some of this this decision rule can really help to make sure that we're matching patients appropriately along this continuum. Because you can see that this is this also matches our CPT coding levels in terms of billing. So this is already set up to help patients move from that outpatient or even lower than that, a peer support level, all the way up to an acute medical setting. There's also a lot of evidence that really supports using the ASAM model, or really any matching model, because when we don't use something data-driven to help us match our treatment recommendations to what the patient needs, we're not helping them as much. So you can see this is a study that looked at cocaine users and people using heroin, and looked at their appropriateness of match and how that impacted no-show to treatment. So you can see when the patients were mismatched, so they were recommended to go either to a higher level of care than they needed or a lower level of care than they needed, then that impacted their engagement with that program and increased their no-show rates. So when we match, we improve that kind of engagement process. This study also looked at dropout improvement and then step down at the same thing, looking at that with ASAM match. So what was recommended in terms of that continuum of care was very predictive of how well a person was going to do. So if they were undermatched or overmatched, they didn't do nearly as well in any of the variables as if they were matched appropriately. So we used some sort of tool that assessed them and said that, you know, it's recommended that they need intensive outpatient, or it's recommended that they need an RTC, or it's recommended that it's okay for them to stay at an outpatient level, or maybe they actually don't even need outpatient because they don't meet full criteria for a substance use disorder. So being able to do that matching is really important. So the ASAM model or criteria has good face validity, good reliability and feasibility, good predictive validity for a number of substance use disorders and co-occurring conditions. And so if it's something you're not familiar with, I would very much encourage you to consider getting some training in that model. Another model that has really good data and evidence that supports it, which is kind of a big picture model that a program could adopt, is Aspert, which stands for Screening, Brief Intervention, and Referral for Treatment. So this is where, again, everybody gets screened, so universal screening, and using a standardized screening tool, and it can start in any healthcare setting. And in fact, Espert's been applied to a lot of emergency department settings and shown really good data to support it. So you kind of catch who's at risk and then proceed from there. And then they within Aspert, people that are trained in this model are given some steps to do brief intervention, which is a type of conversation that you can have about somebody's risky use in as little as 7 to 15 minutes. So it doesn't need to be something that you schedule down the road. It's something that you do right then after you screen them. And it provides feedback and education on their use, and has shown that some people will change right at that juncture. So especially if we're catching them in that risky zone, before we're catching them at their, that dependent, they meet criteria for a use disorder, but we're catching them in the risky zone, we can make a lot of change really quickly with just this very brief intervention. And then if they're falling into the higher levels of risk, make the determination, do we refer to further treatment or specialty treatment? So here are the kind of the 6 steps for doing that brief intervention. So providing information about the screening results, having a very short conversation about why they use and sort of what their reasons are, their perceptions about it, talking about the risk that's been flagged, right? What they like, don't like, what they may consider changing, giving them some advice on how they can decrease or mitigate that risk, even if it requires teaching a brief skill or encouraging tracking or something like that. And then making the determination, does this patient need follow-up on this particular condition? How are we going to do that follow-up? And do we need a referral to a place like ASAP or a specialty treatment center? There's apps, there's all kinds of toolkits available on the SAMHSA website. So I've given you just a link to the Aspert app, but you can just Google Aspert if you're interested in this. It's a really nice model that, again, everybody gets screening, and that should be done at the beginning of any first encounter, so any intake. And then again, if you haven't seen them in a while, so kind of at a minimum every 3 months, we do a screening, and you could include not just use disorder screenings, but also mental health screenings like the PHQ-9 or the GAD-7. And that lines up with, if they're in no risk, then that's really just your monitoring. You just do it again the next time the time window opens up. They're at that kind of moderate risk, then you would provide some education. Moderate to high risk, that's where you're going to use that brief intervention and maybe even a little bit of motivational interviewing techniques, or kind of that spirit of motivational interviewing. And then if they're falling into the severe risk category, that's when you'll do all of the above and follow up with a referral to a higher level of care or specialty level of care. So in terms of the screenings that can be applied to either the ASAM or the Esper model or other models that we didn't talk about today, but models that help to sort of move from that universal screening into the diagnosis and treatment planning process. But really, in general, screening helps us to target unhealthy or problematic behaviors, including substance use, that we can ideally catch early. But at a minimum, we're catching them when they are a problem and get them into the kind of right treatment plan to deal with that. They're meant to detect the entire spectrum of the healthy behaviors. So for instance, the Columbia, which is a suicide risk assessment or suicide risk screener, flags a lot of people for high risk when they're not actually high risk when you do a comprehensive risk assessment, because it's meant to catch a big pool of people. So the likelihood of it flagging positive is much higher on a screening tool. So we don't want to use that for diagnosis, but it helps us to say, okay, of these 10 people, 5 of them screened positive. Now I'm going to have a more in-depth assessment or conversation with these 5 people. Maybe only one of them actually is going to meet criteria for a condition or something that I need to have a discussion with them. But when we do this, it improves the likelihood that the recommendations for treatment and follow-up are going to be improved, which then improves prognosis. There is a difference between screening and assessment. So screening should occur usually, ideally at intake, ideally before you even really get them in the room. We give them some screeners to do so you have an idea of what you need to talk about and what guides that. It's really meant to be a filter for the substance use disorder, mental health concerns, and risk, like I said, even suicide risk. It can be used in a variety of settings. So it can be something on paper and pencil that you have them do. It could be something that an MA does with them. It could be something that you do. A clinician could ask those questions. However you want to do it. The nice thing about screeners is they're really brief and usually really easy to apply to a number of different settings. Once somebody is positive on a screen, then that leads to an assessment. So the assessment occurs after the screening, and that's where you really gather a lot of key information to be able to conceptualize their problems, make some diagnoses and a treatment plan. So that's part of sort of that general H&P or that intake psychosocial that's going to be done when somebody's starting care. So the screening applies to everybody, and then the assessment would apply to people where we're really trying to focus in and make some much more informed decisions about their treatment. So some commonly used screening tools within the substance use disorder population that I'm going to show you here in a minute is the CAGE, CRAFT, Audit, Dast, INM Assist, and then things that we might use for symptom tracking. More on the medical side would be COWS, CEWA, and UDA or UDS. So the CAGE we don't see used that often, although we can use a modified CAGE for kind of making some screening for behavioral addictions like gambling disorder. But it's an older tool. It's specific to alcohol, which is why you don't see it used as often these days, but it's just 4 questions and it's suggestive of a lifetime diagnosis for an alcohol use issue. The nice thing about it is it can be used as a teaching tool to help patients kind of understand a standard drink. So you can see standard drink sizes are on there. And so you can have that conversation with them. It does produce a different score for men and women. It is just a yes or no. And the CAGE stands for cut, annoyed, guilty, and eye opener. So ask these questions, yes or no, and then that gives you a total score, which produces the screen. Now, the audit was developed by the WHO to be able to be a little more inclusive than the CAGE. So it's kind of the next iteration following the CAGE. It also produces separate results for men and women, so you can see they have a different score. The only difference between the Audit C and the Audit is the Audit C is the brief version, it's the first 3 questions, and then the Audit is the whole tool, which is all 10 questions. So you can use this really flexibly. You could only administer the first 3. If they're negative on the first 3, you don't need to continue, or you could just routinely ask all 10. It can be used very flexibly that way. So you can see this is the Audit, and then the Audit C are just those first 3 questions. The nice thing about this instrument, even though it's only really focused on alcohol, is it does give you more data. So rather than a yes or no, it's giving you frequency data and on a Likert scale. So you get a lot more information when you use the Audit. Now, we routinely use the Audit even on our opiate use disorder population because we know that alcohol is still the #1 most abused substance in the country. It's widely available, and a lot of times patients will underreport or minimize their alcohol use. And so just applying an alcohol screen to everybody you see is recommended by the CDC, the WHO, SAMHSA, even if you're not actually treating for alcohol, but to use this as a screener for everyone. A screener that we also recommend that captures substance use in general, and this can be applied to any use disorder. So no matter what drug it is the person may be using, is the Dast. And this comes in a 10 or 20 item version. I'm showing you an example of the 10 item version. There's also an adult and adolescent version. So this ranges from 14 and above. The nice thing about the Dast is it's not specific to the use behavior. What it's capturing is the functional impairment. And so in terms of helping to make a diagnosis of a use disorder, this helps us to see what level of consequences a patient may be experiencing as a result of their use, regardless of what substance it is or how frequently they're using it or not. The other nice thing is the score that it tallies aligns with SAMHSA criteria. So when you look on the scoring page of the Dast, it will tell you if their score is recommended for outpatient level of care or IOP or RTC. So it will tell you which level of care is appropriate based on their Dast score. Probably our more advanced public domain assessment is the INM Assist, which stands for NIDA, Modified Alcohol, Smoking, and Substance Involvement Screening Test. This you can use as a paper version, or you can use the web-based interactive tool, which I would recommend. It also aligns with SAMHSA criteria and Aspert, which is really cool. So it's kind of the best of all worlds. So it has 8 questions evaluating 10 different substance classes, which is your initial screener. And then it goes into more detail based on what they say yes to. So if they only say yes to marijuana and opiates, then those are the only questions that it's going to really ask them in detail and help to determine if they are falling into a risky category. At the end, it will say a leveling recommendation. So what level of care would be recommended based on their answers, and also some brief intervention or community referrals that are recommended. The clinician can do it with the patient, or like I said, the patient can do it. There is a printed version that you can get, and you can also play around with the interactive tool, which is really cool. So if you have access to a iPad or something that you can give patients to do while they're waiting, this is a really cool one to have. The other set of screeners are things like symptom trackers, and you probably already use this routinely if you're treating opiate use disorder. So the clinical opiate withdrawal scale, which helps you to track their withdrawal level kind of over time and making decisions about medication. And then the tool that we use for alcohol, which is the CEWA. And then the other thing that we use as an objective measure to balance some of these self-report measures that or screeners that we just talked about is UDA or UDM. And so really using that as routine part of care can oftentimes catch things, but you want to think about how often you give the UDM is depending on kind of what you're concerned about, because the detection window is different for each substance. And then I wanted to just pause and ask Dr. Jacobson or Dr. Gadomski if they had any other things to add with these medical screeners before I wrap up.
So thanks, Dr. Milley. No, I mean, I think that everything that you said as far as the CEWA and the cows, we would be using more kind of to assess the acuity of withdrawal and need for medication, both in the clinical setting and sometimes patients, depending on kind of their presentation and their resources, may or may not rely on them at home occasionally when we're doing more outpatient treatment for people. And then this, the urine tox, you know, the one on the right column is the one that we would usually be using in our clinical setting, of course. And also that it's not always going to be reliable if it's not a conformation or metabolite. So also just to keep that in mind when using this tool. I don't know if Dr. G has anything else on that.
No, I think you covered it. Thank you.
Terrific. So then lastly, I wanted to wrap up with some, and this is we always recommend if you're going to assess for substance use, also assess for the common comorbid conditions. So thinking about adding things like the patient stress questionnaire, which is a 2-page form, it's public domain, and it includes the PHQ-9, GAD-7, PC-PTSD, which is just 5 questions that help you to rule in or rule out a possible PTSD that may be there, and then the audit. So the patient stress questionnaire is a great tool, or you can use any of these standalones. The other thing that's also recommended in a lot of the regulatory bodies is including a functional assessment like the Dast, so kind of getting at how are they doing with daily life functioning, and a quality of life assessment. So that helps us to have really informed discussions about why or what they might be willing to change. So thinking about integrating some of these instruments into your intake packet or your reevaluation or whatever can be really helpful. And you can get all of those at this link because they're all publicly available screening tools. Now, comprehensive assessments, you guys are all very familiar with. So this is just including kind of what's recommended for a comprehensive assessment. The only thing that I highly recommend that we don't do routinely is collecting collateral and making sure that you've done a really thorough chart review. Oftentimes it's hard to get people to agree to let us call somebody in their life, but I can't tell you how helpful that is to have an idea of what else might be going on, what problems their family member or their loved ones are seeing, and to really kind of flush out that self-report. The same thing with a chart review. Oftentimes a lot of really good stuff has been done, but we don't always have time to kind of integrate those pieces into all of the other things that we routinely collect. And so here are some static, so templated assessments that are available. The ASI, the brief symptom inventory, the opiate treatment index. These are all things that are available that you can use to guide doing that comprehensive assessment. And then the other ones, timeline follow-back, Form 90 gains, these are specific to the substance use population that you would know if you really want to collect a ton of information. So we tend to not use them as part of clinical practice, but we'll see them in different research settings. So that's it. I don't know if anybody has a brief